Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. Today, my name is Terry Fletcher. So today I'm going to talk about a topic that I actually said I was going to talk about a couple weeks ago, but we got sidetracked with some of the latest news with Medicare. So I'm bringing back the topic because I think there's some confusion on advanced primary care management services. And I mean confusion because I see a lot of practices have switched from chronic care management and principal care management to advanced primary care management services because there's no time-based thresholds. Now, I understand that because the administration said that, this should reduce burdens, but there's still so much paperwork, so much information that has to be processed and created to provide advanced primary care management services that I want to make sure you are aware that it's not easy going as you might think it is. And we're talking about HCPCS codes G0556, G0557, and G0558. So remember, G codes are Medicare codes. They say, G, we're watching you, so they are temporary, and they are basically looking at should these be converted to Category 1 codes. Now, the elements of care management services that we have in principal care management, chronic care management, the extensive chronic care management, even transitional care management, those are still reflective of a lot of things in the advanced primary care management services. Again, just no time-based thresholds, but there's also some different things when it comes to chronicity of the patient's condition. Were they a qualified Medicare beneficiary, meaning that not only in addition to 2 or more chronic conditions, they also have a status that needs special attention for medical and or social complexity. Maybe they are special needs where they don't have access to care or they have some psychosocial issues. And so that's why you need to really follow up with them for virtual care. So there's 3 levels. G0556 is for persons with 1 or less chronic condition, which means they may not even have a chronic condition, but they still need help with their day-to-day to make sure that they are fulfilling their medical appropriateness to be able to, continue with their care. It's hard to explain where I'm trying to go with that. Level 2 G0557 is for persons with 2 or more chronic conditions. And then level 3 G0558, that is for 2 or more chronic conditions. And again, the status of the qualified Medicare beneficiary, which means they need extra help. Now, the reimbursement from 1 to 3 goes from $15, $50 to $110. That's per month. Now, a reminder, the documentation has to reflect first who the billing practitioner is, consent, because the patient will have a share of cost, an initiating visit, but there's some caveats there, 24/7 access to care and care continuity, comprehensive care management, comprehensive patient care plan, management of care transitions, ongoing communication of care coordination, so community services, virtual communication options, so does the patient have access to the provider, patient population management, and performance measures reporting. So you have a lot that you still have to do here. Also remember, and this is the most important thing because I'm seeing some reports, and I've had even a couple clients tell me that they were going to have the APCM available for the patient and enroll them, but if they didn't use it, they were still going to bill for it. And I'm like, wait, what are you talking about? They said, well, the patient, since there's no time threshold, it's up to the patient to use it or not. As long as we have it available, we can bill for it. No. This is a patient interaction and reciprocal patient-provider exchange. That's what reflects medical necessity, or why even have the patient into it? If the patient does not participate or access these services, it's not billed. This is not a gym membership. This is not like saying I'm going to 24-hour fitness or I'm just going to, pretend that I'm going to go to the gym, but I have the gym membership in case I want to go. That's not what this is. This is advanced primary care management. This means that these patients have a problem that you have to deal with to make sure that they are meeting their continuity and care And we have to be very cognitive of that when we are reporting these services. So let me give you some differences so that you understand the difference between APCM, chronic care management, and I'll give you the key difference. So first of all, the billing practitioner. So physicians, nurse practitioners, PAs, certified nurse midwives, and clinical nurse specialists qualify to be able to support this. It's anyone that can bill directly to Medicare. CCM is the same. Services that are designated as care management and can be provided through auxiliary staff under the supervision of the provider. Still, you can do that. And it is or intends to be responsible, this is the provider, for the patient's primary care services and services as the continuing focal point for all needed healthcare services. So the difference between APCM and CCM here is the key difference must be or intend to be responsible for the patient's primary care services and serve as the continuing focal point for all needed care services. All, not some, not a couple, all. Is that what you plan to do, and how are you documenting that? Now, consent. Okay, so for APCM, you have verbal consent. You need to make sure that you do it before you initiate services. Same with CCM. Obtain once, unless the patient switches to a different physician or practitioner. Same with CCM. And then here's some similar, and I'll tell you the differences here. Consent must inform the patient of possible cost-sharing responsibility. Only one practitioner may provide and bill APCM during a calendar month, and right to stop APCM services at any time. For CCM, same thing, except they also have to reflect the availability of CCM services. So you have to get consent, and consent's about money. Patient needs to know that what you are reporting, they're going to see that they have a patient responsibility or share of cost. Now, what about that initiating visit? Okay, so with chronic care management, they're required for new patients or patients who have not been seen within the last year, and that can happen during evaluation, a management visit, annual well, or initial preventative exam. For APCM, required for new patients if the patient has not been seen in the practice in the previous 3 years or has not received other care management service from the practice in the previous year. And the only difference here is only required for patients who, again, have not been seen within the past 3 years. CCM is 1 year. Eligible beneficiaries. So all Medicare beneficiaries for whom the billing physician or practitioner has assumed or intends to assume the responsibility for all primary care services. That is such a huge comment. You're assuming all primary care services and continue to be their focal point. So for those practices that are billing that G2211, this is probably where they're going to look to see, are you also doing this? Medicare for CCM, Medicare beneficiaries with 2 or more chronic conditions that are expected to last at least 12 months or until the patient's death, or that place them at significant risk of death, acute exacerbation, or decompensation, or functional decline. A little bit different there. They're trying to get really sick patients versus patients who have conditions that may need to be followed up on. So time thresholds, none for APCM, but you still have to be able to reflect what you're doing. So they're not stratified by time, but you still have to see who's making the medical decisions, and it has to be clear within the documentation. Now for CCM, non-complex CCM, that's broken down into either 20 minutes or 30 minutes, or complex, which is 60 minutes. So it depends on what you're going to need for that. Access to care or care continuity. Now, this is something that I was just auditing a practice that had enrolled just every single patient into APCM, and before that, they enrolled every single patient in CCM, and patients were not happy. And so they said, can you look at this? What are we doing wrong? Well, they didn't have 24/7 access for urgent needs to care team practitioner, including providing patients with a way to contact healthcare professionals in the practice to discuss urgent care needs regardless of the time of day or day of week. After hours communication, you have to have availability. Same with CCM. So let's just say what that means is, let's say you've got an elderly patient who forgot to take their meds that day. They've got those little days of the week pill boxes, and they forgot to take them. They panic, let's say they're 80 years old and they need to call someone. And instead of calling the ER, which they usually do, they have to be able to call somebody on your care team and get an immediate response. So if you don't have that person with, we don't call it a pager anymore, but with a cell phone that's available, that's on call for a care management patient, then you don't qualify to bill for these services. And this is the one difference with APCM and CCM. In APCM, you must offer alternative ways to receive care, such as home visits or expanded hours. So that's why they relieved a little bit of the time paperwork burden, but you still have now more of a clinical burden, in my opinion. Now, comprehensive care management, you have to make sure that you have systematic needs for assessment for medical and psychosocial for APCM, system-based approaches to ensure receipt of preventative services, medication reconciliation, management, and oversight of self-management. You have to keep up on these for patients. Same thing with CCM. Access the patient's medical, functional, and psychosocial needs. Make sure the patient gets timely recommended preventative services, review medications and any potential interactions, and oversee the patient's medication self-management. That is probably two of the biggest things for any care management services. And then you have to have a patient-centered comprehensive care plan, not just for CCM, but also for APCM. Develop, implement, revise, and maintain an electronic patient-centered comprehensive care plan. And they have to be available to any payer that wants to see it. On CCM, create, revise, and monitor a person-centered electronic care plan based on physical, mental, cognitive, psychosocial, functional, and environmental reassessments and inventory of resource support. So I've seen now that basically you enroll them in the service, and then I don't see these patient-centered comprehensive care plans. So they have to be updated with the care team. A copy needs to be given to the patient. Provide, all the not just updates, but are they getting better? Are they getting worse? What are you monitoring? Management of the care transitions. So it requires the coordination of care transitions among healthcare providers and settings, including transitions involving referrals to other clinicians, follow-up after an emergency department visit. It almost sounds like transitional care management. Or follow-up after discharges from hospitals, SNFs, or other healthcare facilities. Same thing with chronic care management, referrals to other clinicians, or follow-up after ED visits. Very similar. And the difference would be the APCM requires practices to make reasonable efforts to provide timely follow-up communication after discharge from a hospital or facility setting within 7 days when possible. So when they say when possible, it means you better document why you didn't. Okay, so there's a lot of similarities. The practitioner home and community-based care coordination. Again, documentation has to be the key here. Ongoing communication and coordination of needed services for that patient. What do they actually need? Why are you having them enrolled in this? One of the differences between APCM and CCM is expanded ongoing communication and coordination for home-based service providers, community-based service providers, hospitals, skilled nursing facilities, and expanding any kind of communication that they have for psychosocial needs. And what are the goals? Goals are important. And I'm just going to give you some titles of some other things, and then you really need to research this out. Enhanced communication opportunities, patient population level management. This is a new requirement. Analyze patient population data to identify gaps in care and offer additional interventions as appropriate. We don't have that with CCM. Risk stratify the practice population based on defined diagnosis, claims, or other electronic data. So that targets your patients. Do you have a population of patients that don't have access to care, that are homeless, that are in a certain income bracket and can't afford their medications? Performance measurements. This is a new requirement, APCM, that CCM doesn't have. Be assessed on primary care quality, total cost of care, and meaningful use with the use of the certified EHR technology. You have to register and report these patients in your MIPS value pathway. So before you enroll a patient in the APCM, make sure that you know the extensive documentation that is needed to be able to support what it is that you're doing. The fact that they pay for these services is a gift, and so we don't want to squander that gift, but just make sure that you have somebody or a team in charge of how the documentation and how the compliance of all these services work. down to the codes, the documentation, what's needed, what has to be included, the access for patients, etc. Otherwise, you could be caught flat-footed once it's going to be looked at. You know, all these services are looked at. As soon as they give us something new, they say, okay, let's see how everybody's doing with it. You know, for a little personal tidbit, if you haven't figured out what to watch, now it's baseball season, so I think I've lost my husband for the next 7 months. But there's a couple of Netflix shows. I'm actually looking at the new Suits. We've watched 4 episodes, and it's kind of depressing. It's not the same as the first Suits, so I'm waiting to see if it gets better, so we'll see. But there's one on there called The Residents, and it's pretty funny. So just check that one out, see what you think. There's 8 episodes for the first season. I hope it gets renewed, but it's not what you think. So try that one out. All right, everyone, have a great rest of your week. Make it a great day. And thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.